Shock terminology definition. Types of shock listed. Clinical features of shock. Hypovolemic shock, cardiogenic shock, septic shock, anaphylactic shock. Miscellaneous. Brian Angus Pathology Department, University of Newcastle upon Tyne. Return to Cardiovascular Pathology Index page. Terminology: emotional/psychological electrical cardiovascular. This presentation concerns acute circulatory failure, cardiovascular shock. Shock terminology definition. Types of shock listed. Clinical features of shock. Hypovolemic shock, cardiogenic shock, septic shock, anaphylactic shock. Miscellaneous. Definition: acute circulatory failure. The clinical syndrome resulting from acute circulatory failure. Shock. Terminology. Definition. Types of shock listed. Clinical features of shock. Hypovolemic shock, cardiogenic shock, septic shock, anaphylactic shock. Miscellaneous. Types of shock: cardiogenic, hypovolemic, septic, anaphylactic. Miscellaneous. Pancreatitis, neurogenic, blood transfusion. Shock. Terminology. Definition. Types of shock listed. Clinical features of shock. Hypovolemic shock, cardiogenic shock, septic shock, anaphylactic shock. Miscellaneous. Clinical features of shock. In acute circulatory failure, the patient typically shows the following: restless, confused, pale, cold, sweaty, peripheral cyanosis, rapid weak pulse, low blood pressure, drowsiness, coma. Shock. A. Terminology. B. Definition. C. Types of shock listed. D. Clinical features of shock. E. Hypovolemic shock. F. Cardiogenic shock. G. Septic shock. H. Anaphylactic shock. I. Miscellaneous. Hypovolemic shock etiology. Hemorrhage. Burns, greater than 10% surface. Vomiting/diarrhea. Hemorrhage, volume effects. Loss 10%, no effect. Loss 25%, hypovolemic symptoms 36 hours. Loss 50%, coma, death. Loss of blood volume, early compensatory changes. When blood is lost, the body reacts specifically to preserve blood supply to the brain and heart. The adrenal gland secretes catecholamines which increase peripheral resistance, raising the blood pressure. The kidneys secrete renin which retains sodium and thus water by the renin-angiotensin system. Loss of blood volume, management 1. These early compensatory changes suffice if less than 25% blood volume lost. If 25% blood volume lost, then transfusion is required as there is a risk of shock, dependent upon the age and health of the patient. Loss of blood volume, management 2. Transfusion is ideally done with cross-matched whole blood. Macromolecular solutions and saline can also be used. Loss of blood volume, management 3. In assessing response to transfusion, measurement of central venous pressure, CVP, using a catheter inserted into the right side of the heart gives a better idea of the true circulatory status than simply measuring the blood pressure, which can be maintained by the compensatory mechanisms described until a critical situation is imminent. Hypovolemic shock late effects 1. If blood volume is not restored, the following events take place, resulting in a critically ill patient. Circulation becomes sluggish because arterioles relax and the vascular beds fill with subsequent departure of fluid into the extravascular compartment. This results in hemoconcentration. B. Blood viscosity is raised because red cells form mulos, and the blood fibrinogen is raised. Hypovolemic shock late effects 2. If blood volume is not restored, the following events take place, resulting in a critically ill patient. Damaged endothelium releases thromboplastins which trigger the coagulation cascade. This results in disseminated intravascular coagulation, DIC. Blood clotting factors are consumed and the patient therefore has a bleeding tendency. Hypovolemic shock late effects 3. If blood volume is not restored, the following events take place, resulting in a critically ill patient. Lack of oxygen in the tissues results in metabolic acidosis. This depresses myocardial action. Damaged cells release potassium resulting in hypokalemia. Corticosteroid action, from the adrenals, results in hyperglycemia. Hypovolemic shock late effects 4. If blood volume is not restored, the following events take place, resulting in a critically ill patient. Widespread ischemic damage occurs. Brain, neuronal necrosis. Kidney, acute tubular necrosis. Heart, subendocardial infarction. Shock. A. Terminology. B. Definition. C. Types of shock listed. D. Clinical features of shock. E. Hypovolemic shock. F. Cardiogenic shock. G. Septic shock. H. Anaphylactic shock. I. Miscellaneous. Cardiogenic shock, causes. Myocardial infarction and its complications, for example ruptured papillary muscle, result in acute pump failure. Mortality is high, at least 80%. The effects are similar to hypovolemic shock, but of course management is different as there is no urgent requirement for fluid. Shock. A. Terminology. B. Definition. C. Types of shock listed. D. Clinical features of shock. E. Hypovolemic shock. F. Cardiogenic shock. G. Septic shock. H. Anaphylactic shock. I. Miscellaneous. Septic shock, causes. Septic shock is caused by bacterial endotoxins or exotoxins in the blood. The toxins can be released, for example from bacteria in a focus of sepsis such as an abscess, or from bacterial growth in the flowing blood, septicemia for example meningococcal. Exotoxic and endotoxic shock. Septic shock, endotoxic and exotoxic. The diagram shows production of exotoxins by bacteria which remain intact, left. This contrasts with endotoxic shock where the whole bacteria break up and cell wall lipopolysaccharides activate the complement and coagulation cascades. In practice endotoxic and septic shock are often used synonymously. Septic shock endotoxic, etiology. Gram-negative endotoxins. Cell wall lipopolysaccharides. E. coli. Proteus. Klebsiella. Bacteroids. Pseudomonas, burns. Meningococci. Septic shock exotoxic, etiology. Gram-positive exotoxins. Much rarer than endotoxic shock. Example of cause, Staph aureus skin infection. Toxic shock syndrome. Staph aureus in tampons. Septic shock etiology, sources. Infected burns. Septicemia. Localized infections. Instrumentation for example urogenital. Immunosuppression, septic shock mechanism. The toxins from bacteria damage endothelium. Nitric oxide, NO, is released which causes vasodilatation. Unlike hypovolemic shock there is no vasoconstriction phase. However, as with late-phase hypovolemic shock, endothelial damage results in DIC as previously explained. Septic shock example. This is the hemorrhagic rash of meningococcal septicemia. Prompt treatment can prevent the condition on the next slide. Septic shock, example. The brain is covered in purulent exudate, this is meningococcal meningitis. University of Newcastle upon Tyne. Shock. A. Terminology. B. Definition. C. Types of shock listed. D. Clinical features of shock. E. Hypovolemic shock. F. Cardiogenic shock. G. Septic shock. H. Anaphylactic shock. I. Miscellaneous. Anaphylactic shock. Etiology. Histamine release from blood basophils. Drugs, for example penicillin. Stings. Foods, for example shellfish, peanuts. Vasodilatation, blood pressure drops. Anaphylactic shock, mechanism. Antigen, for example wasp venom accesses specific IgA on blood basophils. IgA dimerizes at the cell surface and the basophil releases histamine by degranulation. Vasodilatation causes the blood pressure to drop. Clinical features of shock develop rapidly. Anaphylactic shock, mechanism. Anaphylactic shock, treatment. Adrenaline and hydrocortisone are given in the acute phase. The patient may recover without further specific treatment. If not, full support in an intensive care unit will be required. Shock. A. Terminology. B. Definition. C. Types of shock listed. D. Clinical features of shock. E. Hypovolemic shock. F. Cardiogenic shock. G. Septic shock. H. Anaphylactic shock. I. Miscellaneous. Miscellaneous causes of shock. Neurogenic, for example severe head injury. Pancreatitis, enzymes damage endothelium. Blood transfusion, incompatible. End of presentation. Return to cardiovascular pathology index page. Shock. End of presentation. Return to cardiovascular pathology index page.